Hi, I'm Christopher King. I'm the Associate Medical Director of the Advanced Lung Disease and Transplant Program at Inova Fairfax Hospital in Falls Church, Virginia. And this is the concluding video on a series of videos that discusses how your pulmonary hypertension specialist incorporates information to develop a treatment plan that works for you and reviews the different classes of medications that are available to use when making that treatment plan. And so everybody's plan is unique with pulmonary hypertension. And there's a number of factors that your PH specialist will take into consideration when developing a medication regimen for you. And some of that includes the type of pulmonary hypertension. So in certain instances, pulmonary vasodilator medication may not be appropriate. In others, you may need numerous pulmonary vasodilators combined together. They also need to take into consideration the severity of your illness, your comorbid medical conditions, because some of these medications don't do well. For instance, if you have concurrent heart failure or impaired relaxation of the heart. They'll have to take into consideration your prior tolerance of medications, your ability to manage complex medications like continuous IV infusions, if that's something that would be indicated for you. They also need to take into consideration your preferences for your treatment plan, because it's certainly important to know what kind of things you're willing to do or interested in doing and what works best for your lifestyle. And then they also have to monitor your response to therapy and adjust over time. So one question that your pulmonary hypertension specialist will have to answer is whether you should be on a single medication or a combination of medications. In some situations, just one medication that dilates the blood vessels is appropriate. Some examples of this are patients with significant cardiopulmonary comorbidities, patients with very advanced age, or patients that are what we call calcium channel blocker responders who may just require one of those medications. More commonly, we use combination therapy, however, and there was a study called the Ambition trial that looked at whether you could use two medications that were started upfront as combination therapy as opposed to starting one medication and then in a delayed fashion adding a second medication as a step-up therapy. And that study found that it was actually, even though it was only separated by the course of weeks, patients that got upfront combination therapy had a reduction in their risk of disease progression and sort of adverse outcomes. For that reason, we often try to use early combination therapies. So there, as I mentioned in some earlier talks, there's 4 different distinct pathways that we have medications that we can target. And so, not every patient requires a medication for all of those pathways, but your clinical specialist that's treating you will evaluate you and see if you would benefit from some combination of medications. They would only use one medication per pathway in these combinations. And so at most, patients will end up on 4 medications for pulmonary hypertension. But as I mentioned, it's not clear that all patients need 4 medications. There's actually guidelines that your pulmonary hypertension specialist can use as a general guide, although oftentimes you have to modify things based on the patient's individual circumstances or their response to therapies and not follow the guidelines to a T. When you're being seen by your pulmonary hypertension specialist, we'll often do an objective risk stratification tool, and this is one example of that. This is the European Society of Cardiology, European Respiratory Society risk stratification tool, and it takes into consideration a number of factors and can sort of label you as a low-risk patient, an intermediate-risk patient, or a high-risk patient. And then this is a simplified version of that only incorporates sort of factors that are measured more frequently. Some of the things in the earlier chart don't really change visit to visit. And this also breaks the intermediate category, which can be sort of a broad range into sort of intermediate low or intermediate high risk. And so the goal of your treating physician will be to try to drive you down to a low-risk category when we want to see patients feeling as well as possible and in that low-risk category if at all possible. This is an algorithm that has been developed since the development of a new medication called sotatercept to sort of incorporate how you think about using all these medications together. And so if you look at somebody and you risk stratify them and they're not high risk, then it's typically early combination therapy with two oral medications, where if patients are high risk, in those patients you should really be considering something from that prostacyclin class of medications. And oftentimes it may be IV or subcutaneous medication. And then once you start medications, you want to re-risk stratify patients. So if patients are doing well and they're in that low risk category, you can continue their medical therapy. If patients aren't hitting those goals, there's a number of different ways that you can add additional medications. They also highlight if patients remain in a high-risk category despite aggressive treatment, that lung transplantation in certain situations can be considered. And so, as you can see, it's a pretty complex process. It requires frequent reevaluation, and there's sometimes a little bit of trial and error because not every medication works for every patient. And so your pulmonary hypertension specialist and you need to collaborate to figure out what the right combination of medications is for you. So as I mentioned, every case and every treatment plan is unique. Most patients will be treated with combination therapy, although there are instances where just a single medication is okay. There's a lot of different factors that go into developing your treatment plan. And then again, you need to be following up closely with your pulmonary hypertension specialist and then continually reassessing the response to treatment and adjusting the treatment plan according to how you're doing. Thanks for your attention today. For more information or resources, please visit phassociation.org.